Right, Elif, should we get started? Because it seems like the sort of people who are joining have joined, a few people possibly may join in the next few minutes. So we'll start with some introductions. So my name's Amita Jassi. I'm a consultant clinical psychologist, and I work in the same service with Elif, and we both work in the National Specialist Service for young people with body dysmorphic disorder and other related conditions such as OCD and trichotillomania and other kind of related disorders. Over to you, Elif.
Hi everyone, I'm Elif Gocken and I'm a senior clinical psychologist in the National Specialist OCD and BDD service at the Maudsley, and as Amita said, we work alongside each other in the clinic.
Well, welcome to the webinar today as part of this autumn series. So today we're going to be thinking about body dysmorphic disorder, or BDD, in the context of autism. So that's what we'll be thinking about. And we want to try and make this webinar as interactive as we possibly can, given it's online and so forth. So if there's any questions as we go along, I think the chat function is working. If not, you can raise your hands and ask questions. And yeah, please do that as we go through, because we'll be covering quite a few different topics. So if we move on, it might be harder to kind of think that through a bit later. So if we just think about sort of what we'll be covering today, if we just go on to the next slide. Sorry, Elif has got control of the slide, so you might hear me saying next slide quite a few times. So this is what we're planning to cover today. So we'll be given an overview of BDD in the context of autism. We will be given a summary of research findings and just giving an update in some work that we're working on at the moment at the Maudsley, thinking about treatment for BDD and how we adapt that for young people and also adults with autism. We don't see adults, but we know the adaptations apply across the lifespan. And yeah, as I said, sort of thinking about what that looks like, and just kind of our reflections on working with this group and conclusions from there on. So I'll now hand over to Elif.
Hi everyone. So we'll start off by just quickly recapping body dysmorphic disorder and the criteria for diagnosis. And what we know is that BDD is a distressing psychological condition, and it's associated with intense preoccupation with one or more perceived flaws in appearance. And in response to these and the distress that these intrusive thoughts can cause, people can engage in very lengthy, time-consuming, repetitive behaviours to fix or hide these perceived flaws. And often these are very difficult to resist and control. And we know that BDD is a condition that can seriously affect an individual's everyday functioning and their quality of life, often impacting their education, their work life, their family relationships, as well as social relationships. And this, I'm imagining, is a very familiar sort of idea for everyone. Everyone's quite familiar with this, but it's helpful to have a quick sort of recap before we move on to understanding a little bit more about autism and making sense of what autism is and what might need to be different in treatment. And what we know about autism is that it's a lifelong neurodevelopmental condition that is associated with differences in the way that an individual's brain might have developed, and associated with some needs in various aspects, such as you'll see on the screen, social interaction, communication, sensory needs, behaviours and interests. So we know, for example, commonly that individuals on the spectrum might find it difficult to understand other people's facial expressions. They might find it hard to initiate, make or maintain eye contact. Aspects of communication might be quite difficult to understand. So words and phrases with double meanings, metaphors, sarcasm, for example, particular jokes. Behaviours that are the same and repetitive might be unpredictable activities are sort of benefited from and sought, and changes in routine and adapting to these can be quite difficult. In areas of interest, for example, there could be strong and special interest in certain topics, and individuals might really enjoy researching these and talking about these and repeating activities over and over again. And we also know that there can be particular sensory needs as well. So whether that's sort of hyper or hypo sensitivity might mean that there might be a sensitivity to noise, light, smells, for example. So there can be quite a unique set of needs arising from autism. What we feel is really important to highlight is that along with these needs, that we can tailor sort of treatments we know about autism, is that we really want to highlight the key strengths that we know in autism and the profile that individuals with autism can present. And we know that sort of one aspect of this is the way that information is processed, and how efficient and skilled individuals are in focusing on detail and processing information in quite a precise way. So detecting patterns, detecting errors in patterns, for example, which are all incredibly valuable skills across many sort of professions. Logical thinking, strong memory, for example, are another sort of aspects, as well as the ability to focus and sustain attention and concentration for extended periods of time. And we know that, for example, there's a huge value in and benefits to the style of communication and the way that information can be shared in a direct and honest way. And often there's a very sort of evidence-based feedback that's involved. And again, creativity. We know that there are very sort of unique, different perspectives that come from a logical thinking style and strong interests. And this can often be a very fruitful sort of ground to develop unique solutions to problems, for example. So autism is associated with a huge number of strengths. And just to sort of describe a little bit of background on the research to date with autism and anxiety disorders. What we know is that around 30 to 50% of young people with autism are diagnosed with an anxiety disorder, and 20%, 25% of young people on the autism spectrum have OCD. And I think it's I think what we've noticed more recently in our line of work, that actually this number has jumped up a bit from my experience. And in our clinic, we're actually working with a significantly larger number of young people on the autism spectrum and treating for OCD. And often we're also assessing young people with autism for BDD and treating them for BDD as well. But at the moment, the exact rates for this is unknown. And I don't know if Amita, you wanted to add something.
No, I was just going to say exactly that, and I think that will come through as we sort of go through this presentation, that it's very much based on sort of our clinical observations of BDD in people with autism. We don't have as many facts and figures as we do for OCD, so we don't have a sense of the rates. I guess, I don't know what you think, Elif, from our clinical sort of experience, or in fact I could sort of say something about this, when we've looked at our group of young people that we see, and we should caveat this with saying that we work in a national specialist service, so actually by the time people get to us, they would have potentially tried local treatment, and it might not have gone to plan or not worked. So we've got a bit of a skewed sample in that actually lots of them, part of the reason may be because they also have autism, they end up with us. But when I recently looked at sort of the percentage of young people with who come to us for BDD treatment who also have autism, it's about the same. So about a quarter of those also have autism. But that's not, some of the studies that have been done that have been like Whiteout, they're in bigger samples, it's not skewed samples. So yeah, as Elif said, we don't know the exact rate, but we suspect it's similar to what we see in OCD, but there's not any good studies in that yet.
Yeah, thank you. So that's really important to highlight, and hopefully there'll be sort of more research focusing on these and understanding that as well, which is very much an aim within our service. And I think if we think to sort of BDD and autism, we know that both are associated with repetitive thoughts and behaviours. And one thing that an aspect that we think very carefully about is sort of disentangling in those young people with both conditions, disentangling them, disassociating them, I guess, to see how we can tailor treatment to meet the individual's needs. And in the next few slides, I'll outline the kind of areas that we think about. For example, when we're thinking about the repetitive thoughts, one area that we focus on is on the content of those thoughts. And we know that in BDD, it's very much about aspects of, or multiple aspects of appearance, or how those features come together. And that sort of drives the worry. So things like muscle composition, skin, hair, face shape, for example, those are the contents of the worries, or the repetitive thoughts. Whereas when you think about it in autism, those preoccupations are very much around sort of areas of interest. For example, it might be to do with celebrity, sports figures, or sort of having things just right, or the same, for example. So there's a separation very much there. And then when we think about sort of how much distress those thoughts might be causing, we know that in BDD that they're incredibly distressing and disturbing to the individual. And often along with that sort of feeling of distress, there could be a range of other emotions such as shame, embarrassment, guilt, and that have a huge impact on their mood. So it's very much associated with distress. And when we think about the level of distress in these repetitive thoughts might lead to in autism, we know that there's very little or no resistance to the thoughts, and actually the individual might really wanting to be engaged in these topics, and actually where there might be a bit of distress, it's actually coming from being prevented from doing so. So that's where that sort of separation is happening. And in terms of sort of the impairments these thoughts cause, there's a very clear and definite impairment in relation to BDD. But it's less consistent in autism, in the sense that it might be impairing in the sense that the young person might be really wanting to engage with these, and that's impacting their ability to focus on school, for example, rather than that sort of outright being these thoughts outrightly sort of causing an impairment in their day-to-day life, or that being a consistent aspect. I don't know if there's anything that you wanted to add to this at all, Amita.
No, not at all, but I appreciate there's a question that's come up in the chat about treatment, which we'll come on to shortly. So I just want to acknowledge the question has been seen. I think it's from Melissa, but we'll come on to that in a minute.
Thank you, because at the moment I can't see.
Yeah, we'll have to take it in turn, so I'll keep an eye on the chat whilst you speak and vice versa.
And then we think about the repetitive behaviours and the compulsions. And again, when we look at the content in BDD, it's very much about sort of checking appearance, whether that's in the mirror, other reflective surfaces, using phones or other tools, for example, comparing appearance to others, extensive and very lengthy grooming and makeup routines, for example, or gym muscle sort of exercises that are performed regularly to build certain muscle groups, for instance. And that feels very different to the repetitive behaviours that can be seen in autism, which might be more around stimming, so rocking, flipping hands, for example, playing with objects. That again, when we look at distress, it is associated with distress in autism, and actually it is associated with enjoyment. And again, that distress is from being interrupted from doing these behaviours. Whilst when we think about the distress in BDD, we know that young people will say they don't want to do these behaviours if they had the choice, and they actually feel compelled to and driven to do them. And again, there's a very significant impact in terms of the time these compulsions and repetitive behaviours can take and interfere with all aspects of their life. So being late to school is something that we hear very commonly. Impacting on their family relates to the amount of time they spend with their friends and families, and also avoidance is very common the experience as well, where the young person might stop engaging with certain aspects of their lives because of the distress that those behaviours might be causing them as they're engaging with them. And again, the interference is less sort of clear in autism. It might be that there are some aspects and it interferes with things like attending school or social interactions, but that's not as consistent. And when we think about sort of the trajectory and the onset of conditions, we know that in BDD, it's very much sort of symptoms or behaviours are apparent around the adolescent teen years, and they can fluctuate, but tend to be quite chronic, and they can sort of worsen without an intervention. whereas in autism we know that the onset is very early on, at the point of infancy and 12 months onwards, and the behaviours can be more persistent at the younger stages, but tend to reduce in the adolescent phase. So thinking about sort of content, the distress and the impairment and onset can also support that sort of disentangling, where there's the overlap and where there's a distinction between the two conditions. And I guess one area that we think a lot about is understanding the factors that might make an individual vulnerable to developing BDD, and whether there's something about the strengths that we know exist in autism that might make an individual with autism more vulnerable to developing appearance concerns. And these are areas, for example, we know that in BDD, individuals can process information in a less global way, and more focusing on attention to detail, and zoom in on aspects of their appearance, for example. And it might be that actually this particular skill in autism means that an individual might be more likely to pick up on perceived flaws, for example, and in combination with that sustained concentration, might be stuck examining or stuck performing those rituals. And again, it might be that there could be a limited or lack of tolerance to these perceived differences and changes that might be happening. So that might be another factor, I guess, that can I guess picking up on differences, and sometimes that need for repetition or sameness could be increasing vulnerability to appearance concerns. And I guess we know that this is a population where we know that in the young people that we work with BDD, they're incredibly creative and often come from backgrounds or interested in careers in the arts, for example, and graphic design, and have a heightened sense of aestheticality, which essentially means that I guess it's an idea that refers to individuals' difference in their sort of appreciation and sensitivity to beauty, for example, and therefore in combination with certain aspects such as I guess perfectionism, or needing for things to be the same, and difficulties in tolerating change and different differences, that might mean that there's an increase in I guess that particular strength and creativity. Might the other side of the coin, so that might be there's an increased vulnerability to developing BDD, when you think about, I guess, all those skills coming together and how they might work in increasing that vulnerability.
I don't know, sorry to interrupt there, and I don't know what you think, sort of, because we work predominantly with adolescents, there is something about that time, isn't there, with sort of body changes and all of that this isn't backed with any sort of research necessarily, but just clinical observation, that we know lots of young people with autism really struggle in that time anyway, in terms of just puberty and body changes, and you've sort of described that sort of change being quite tricky, and often then sort of getting quite preoccupied with that, particularly maybe around some of the markers of kind of the body changing and not being the child anymore. So there's just I've noticed that I don't know if you've had people like that, Elif, that you've been treating and seeing, where there is a vulnerability around sort of adolescence and change.
Absolutely. And I think the idea of, when we explore a bit more about puberty and when some of those physical changes are happening, and in combination with, say, hypersensitivity as well, being more aware of some of those changes, and therefore your attention is brought to your body a lot more, you find that very sort of uncomfortable, then is that also an added factor that can make you vulnerable to these forms of concern as well. It's a really, really good point. So I'll now hand over to Amita to think a little bit more about the research. And
this won't take very long because there isn't much research, which I've kind of shared a bit earlier. And I think just as a whole, our research in body dysmorphic disorder and BDD is lagging behind, say, OCD, but things are moving at a pace. So, for example, we now have a treatment, cognitive behaviour therapy for young people, a tried and tested treatment that has really good outcomes. So we're looking at sort of 78 to 80% of young people that we see respond to cognitive behaviour therapy with medication for some of those that need it. So, you know, whilst we're sort of lagging behind the research in OCD, we've been able to use, I guess, some of that research in OCD as a launch pad to help us kind of in that research in BDD. This particular group, so thinking about those that have OCD, BDD and autism, there is nothing on that like published, and we're doing some work in our clinic at the moment. So what we've been quite interested in looking at is drawing on what we've seen in OCD. Is there any differences in sort of the clinical presentation of BDD in those with autism compared to those without? And is there any difference in treatment outcomes? Because what we see in OCD is that consistently what's been found is that those that are treated with cognitive behaviour therapy, CBT, for OCD don't do as well if they have autism compared to those without autism, which has led to now adapted treatments or programs to improve those outcomes. But there's also been some research in OCD that suggests perhaps the clinical presentation of OCD differs in those with autism. So some inconsistent findings have found that kind of they have poorer insight, that there's some symptoms that they might experience a bit more particular obsessions and compulsions, and that their sort of functioning is poorer at kind of the point of before treatment and after treatment. So what we've been doing is replicating that work that we've been doing with OCD and now looking at those young people with BDD and autism. And really interestingly, and this is just kind of very preliminary, there's more work to be done, but just having a quick look at our data, actually what we find is that the clinical presentation of BDD is really similar in those with and without autism. So in terms of the severity, it seems to be the same. So, you know, one would expect perhaps those with autism might have more severe BDD because of all of those vulnerability factors. Maybe they develop it younger and so forth, but actually there was no difference in that. No difference in insight. So we wondered with some of the thinking styles that we see in those with autism, whether that might make them more prone to kind of poorer insight, not being able to see a different perspective. That didn't come up in our research. And actually sort of functioning more broadly at before treatment was really similar as well, which was really surprising because the measure that we take of sort of functioning, we think about sort of their global functioning involving autism, all the related things like and BDD. So actually having both, they were sort of functioning just as well or just as poor as those just with BDD alone. So some really interesting and unexpected findings. The only thing we did find when we compared these groups is that those with autism are more likely to be on medication, not SSRI medication, which is the medication we recommend for BDD, so that's selective serotonin reuptake inhibitors, which is basically a group of antidepressants, but actually sort of other medications that might be added to that. So for sleep, sort of antipsychotics that are sometimes added to antidepressants to enhance the effects of those. That actually, if you have autism, you're more likely to have some of those medications, which we've also found in OCD. So I've just put the figures there. So if we just move on to the next slide, we looked at treatment outcomes for this group. So in a group of 161 young people in total, you can see the group of those with autism is quite small, is 27. When we look at sort of the measure that we use, which is the gold standard measure of BDD severity, they start off at a similar place, which is what I've just described, that they're just as severe, and actually they end up, you know, at the end of treatment in a similar place. So actually there's no difference in treatment outcomes. So this is a combination of cognitive behaviour therapy and medication, which is really surprising, but really good news, I think, you know, that actually doing this treatment does work for this group just as well. And then when we look at, sorry for sort of these acronyms, but this measure in the second graph is a measure of global functioning. They do differ a bit here. So they start off as kind of functioning at the same level as I just described, but by the time they've had treatment, those with autism tend to be functioning worse. So actually the higher number represents better functioning in this graph, whereas the opposite in the other one. So that kind of makes sense because perhaps in this group they do well in terms of their BDD gets better, but they're still left with autism. So perhaps that's why sort of functioning is poorer at the end. This is just very, very early findings. We've got lots of other things we want to explore. So we want to think about whether Other aspects of the presentation are different, like the particular areas of concern, whether they're particularly concerned with some areas compared to those without autism. And we just also have some other measures we want to look at as well to see if there's any differences in their presentation, but also outcomes using other measures such as mood, depression, sort of anxiety. So that's all we have so far. But actually, you know, it's good news overall that this, you know, those with comorbid autism can do just as well in treatment, and that's the thing to take away from this. This then might help with the question which we're going to start thinking about. So Melissa, you mentioned that your daughter does have BDD and autism, and she has a therapist for BDD, and whether a therapist, whether there's a need for a therapist with all for autism. I guess it's not, it depends on the case, but what we will come on to think about shortly is about how to adapt BDD treatment for those with autism. And we wondered actually whether the results that we found in our studies that we're naturally adapting our treatments, because we've got a treatment protocol that's adapted for those with autism, and we wondered whether we are just automatically doing that for those with BDD. So it could be that actually the therapist for your daughter who, you know, knows about doing BDD treatment can make some of these adaptations to the CBT. Having said that, sometimes young people and adults with autism need support for aspects of their autism, not treatment per se, because it's, you know, it's a characteristic, it's kind of, we just got, it's like a personality type. But if there are other parts that are affecting function, as we can see in the second graph, that there may be things that impact, you know, there is support available for that. But if we're thinking about treatment for BDD, adapting that treatment, you know, for those with autism is really effective, and you probably don't need another therapist. But again, I'm just saying this without the detail. Elif, I don't know if you wanted to add anything to that answer to that question.
No, it was just to echo the point that I think some things feel, because of our experience of adapting OCD treatment to autism, it feels like we're doing things a bit more second nature. So it's quite interesting to think about how we are making some of those changes and bring our attention to that, and that's helping inform sort of just building on that.
Yeah. And then there's another question, which is there any research about the overlap of autism spectrum conditions, BDD and eating disorders? And I don't know what you think, Elif. I don't think there is, to my knowledge. I haven't really looked at the literature. I'm not as familiar with the literature with kind of autism and eating disorders. I'm less familiar on that. So I know Kate Chanchura has done lots of work in this area, but I don't think there's anything looking at sort of the overlap. But what might be interesting in what we're planning to do with this group of young people, this 160 young people that we see in our clinic, is looking at the areas of concern and whether, and we do capture shape and weight concerns. So it'd be interesting just to sort of compare the groups on that. And if I don't know if you're aware of any studies or anything on this.
Similar to you, I mean, so obviously there's a huge literature on autism and eating disorders, but not so. I don't think there's been a combination of the three and studies looking at the three, and so I think that's very much sort of still in sort of, I guess, the conception stage of just thinking about what the relevant research questions might be and how we might approach that as well.
Yeah, and I think there is a bit of, you know, I today was actually meeting with our specialist eating disorders team and thinking about, you know, some of those overlaps between BDD and eating disorders, and some of those more what we call transdiagnostic sort of processes, and what's actually similar and what we could be learning from each other. So yeah, it's a really interesting sort of question more broadly, just thinking about sort of those overlaps between sort of some of the processes and characteristics of those with eating disorders and BDD, and where we can learn from each other. Great. If there's no other questions at this point, we'll move on to think more about treatment. Well, before we do that, we'll think about assessments actually. So as you heard from research, we don't think there's anything, you know, particularly different about BDD in those with autism. And so actually our assessments we do in a really similar way. So I mentioned the gold standard measure that we have, for BDD, which is the BDD-Y box, which is the Yale-Brown Obsessive Compulsive Scale, but for BDD. And there's different versions. There's an adult version and there's an adolescent version, which of course we use the adolescent version. And I think here what we've got an example of is the OCD version, but they're very similar. So the way we go through the measure, it has different sections, and it's the same for those with and without autism. We're doing exactly the same thing. So first of all, we ask young people to think about, they get measures before they come through to us, so self-report measures. So like the appearance anxiety inventory, for example, just so they can share any of their appearance concerns ahead of time. And what we find is often young people find it easier to put it down on paper first, because of the shame and embarrassment and so forth that can come with disclosing some of these things. But nevertheless, when they come into clinic, we spend lots of time sort of just doing a bit of a body scan and thinking about sort of the areas of concern that they might have, think about genitalia and all of the embarrassing things that they might not want to talk about, and giving lots of examples of things that we've heard from others. And it's not just particular areas of concern. Those who are familiar with BDD, it could be just the way things are put together, it could be the texture of hair, skin feeling different. That comes up quite a lot in the group we work with. And after doing that, we then ask about sort of there's two components, as Elif described earlier on, the kind of preoccupation and then the compulsions. And so the questions around that are, you know, around sort of how much time is spent on the kind of thoughts and the behaviours, how much distress they cause, how much interference, how much they try to resist and control those. I should say, as well as the body scan, we're also in that measure asking about sort of behaviours that they do. So kind of in relation to checking social media, avoiding mirrors, checking mirrors, grooming, you know, we give a whole range, but we do want to hear from the young person themselves to kind of describe what they do. There's two other parts to this measure. So one is then taking a measure of avoidance, because we know this group, you know, do avoid a lot, understandably, with those appearance worries. And then also insight, which we've talked a bit about sort of how much they think this is a psychological difficulty, and they can see that perhaps, you know, it's not to do with just physical appearance, to a scale of where they just think it is just to do with physical appearance. And that gives us a total score, which it gives us, there's not kind of cut-offs of severity, but it just gives us an indication of sort of where they're at. And in our treatment, we repeat that measure all the way through, because we want that measure to come down. And I'm just thinking about sort of adaptations. I don't know what you think, Elif, but I know there's an example of kind of a thermometer. We might, in our assessment, make it more visual. So sometimes people with autism struggle to put numbers onto feelings. I had that today with somebody in a session. So we sort of try and use ways for them to describe their distress, and so if that makes sense to them. So sometimes a visual thermometer is quite helpful. When we talk about treatment, that's something we think a lot about, but we do it in assessment. And I guess some other clinical, you know, aspects of what we might do a bit differently is I would make the assessment really concrete in terms of, I might say, a typical day. You know, think about a particular day, talk me through. So you got up, then what did you do? Did you check the mirror? And just kind of walk them through and ask them to kind of describe, rather than just asking them for a summary of those things, which is what we base scoring on, because sometimes that's a bit easier for people with autism to sort of run through. And I should say, we also get information from carers and parents and people that are close to the person who has BDD, to get their information as well, because sometimes kind of the poor insight which we see sort of across many people with BDD, not necessarily just those with autism, it's helpful to get other information from those who are observing it more closely. Elif, I don't know, from an assessment point of view, if there's anything else you think we do a bit differently.
Yeah, just to add that some of those visual aids can be really, really helpful in terms of also bringing a shared focus to something away. So it might mean that the young person feels more able to talk about things if they feel like there's, the eye contact is reduced, for example, or just making some more general adaptations that we'll see later on in the presentation that could be helpful with heightened anxiety on the day of meeting new people. It might be that there are other things that we can do in the clinic room, offer breaks, things like that, to take the pressure off a little bit in that sense. But those would be the kind of adaptations that we think about for many people with autism.
Yeah, there's quite a lot of preparation that goes in, isn't there, with our assessments? Like we send a video of just the centre, just because having a sort of a visual representation of kind of where they are, what the process is really helpful. And like you said, and we'll come on to this with treatment, just thinking about some of those other adaptations for, you know, the sort of sensory sensitivities and all of those things are really, really important. So should we move on to thinking now about treatment? I said that last time and then it was assessment. No, we're on to treatment now. So this is our broad brush of kind of what we do in treatment, and we sort of try to stick to a protocol, but we are very adaptive. And this protocol actually represents what we do currently up until recent months, actually, for every young person that we saw. So we offer 20 weekly sessions. I won't go into kind of lots of detail, but you can see that it starts with a period of learning about BDD and how it works. And then the main part of the treatment, as many of you I'm sure are aware, is around exposure therapy, which is about facing sort of fears and being able to tolerate the anxiety, or doing some experiments as well, so testing out some of those beliefs about if they drop some of those safety behaviours, what they think might happen. And there's other additional things we do, and then there's a period of relapse prevention. And you can see sort of on the left that also we do follow-ups for a year, so that's just to share with you a sense of kind of our protocol. What we've recently done, based on some of what we're doing in OCD, is young people that have OCD get an additional 6 sessions. So we're trialing that for a period that now we offer young people that have autism, a BDD in the context of autism, get an additional 6 sessions, and that will become sort of apparent for the reasons for that shortly. So that's a bit of a pilot, but actually in the results that I showed earlier, the young people that did just as well in treatment did get this 20 session package of treatment. So it may be enough, but we just want to see actually can we enhance the impact further by adding those 6 sessions that we have for OCD. So if we go through in a bit more detail. So yeah, I've kind of preempted myself. So we wondered what we do in our OCD treatment is we spend more time in the kind of the beginning phase of treatment around psychoeducation, as we call it. And particularly what we've noticed in our group with young people with OCD, and we think it's similar for those with BDD, is sometimes there's more time needed to understand kind of different emotions. And I think particularly with BDD, you know, we talk a lot about anxiety as being a really important emotion, but there's lots of other emotions that we know come up, particularly with BDD, sort of disgust, you know, shame and other emotions, that it's really important to spend that time to help people understand how they would know how they're feeling. But we also do measurements of these feelings, like rating scales, as I described in assessment. So that actually does take some time and some work, and this is where the creativity really comes in with this group, that you can sort of make your own rating scales and so forth. But again, we'll come on to that. And I think the structure is really, really important. I mean, the structure is important in all of kind of the treatment that we do. We are very sort of agenda focused. There's always a plan. We sort of tick things off as we go through. But I think more so for those young people with autism, I would say I do that even more, make it really visual. So we'd have a handout with the timetable of the session and sort of agree that. And I sort of also go as far as, you know, giving them the same appointment every week at the same time, just to kind of take away some of those anxieties around sort of unpredictability and so forth. Often, and I wonder if we do more sessions also, or what we're planning to do is just having to repeat things a bit more and just ensuring that things are understood before sort of we move on. Because if you think about for people with autism, it's not just, and BDD, you've got a double whammy there, just being in a room, you know, the kind of the emotions are high, you know, feeling really self-conscious, and sometimes that information might not get as, you know, processed as quickly, and there's lots of other reasons, but with it, repetition is really important for this group. And family involvement, so of course we're talking about young people here, so family involvement is kind of part and parcel of what we typically do. For adults it varies, but we're also doing some research at the moment about how families are involved in BDD and how they may be accommodating, and we target that in treatment. But we rely on families a lot in our treatment to support the work that goes on in session, but also outside of session, because in CBT, homework is really, really important. And so we rely on kind of parents and family members to be supporting, their child or loved one with the homework completion in between sessions. And it's good for them to hold lots of information and to carry that over sort of between sessions. And yeah, I would say the communication, it's a different style, I notice, when I'm working with those with autism. Just being really clear and concrete, not using as many metaphors and so forth, being very directive, really tapping into special interests. So today I was doing a session with somebody and it was very much, they love art, so we got talking about that, and using their special interest to kind of get them to do a rating scale was really important. They engaged so much better, and really, really visual. So we do most of our treatment in person now, but even if it's online, I was kind of sharing screen and showing things. So it's very kind of basically playing into the strengths of kind of autism. So if we just go on to the next slide. And yeah, again, I keep sort of saying things that I kind of then come on to, but here are some examples of things. So when we're describing sort of feelings, maybe, showing it in faces, making it really visual. Like I said, sort of the rating scale, some people like traffic light systems. We show lots of graphs about what happens to anxiety and feelings, over time, sort of habituation. And yeah, just kind of as much as possible making it visual. And it takes also the pressure off that interpersonal interaction as well, which can be really tricky for this group. It actually gives you something kind of external to focus on. So now, Elif, if you've got other examples of how you sort of make it kind of make sense of feelings in
I think it's often there have been sort of, like you say, tying it into special interest. So it could be that the rating scale, taps into Harry Potter or Star Wars, or really bringing in those interests and engaging and making sense of the purpose of these particular tools. And I guess at the point that we start thinking about anxiety, for example, and learning about it, might be that we're a few sessions in. So I guess another example might be that a concrete example might be how the young person has found sort of how anxious they're feeling in that moment in time versus how they were at the initial sort of appointment. So that could be a really concrete way of showing, actually, we've started to notice habituation as well. So that could be a nice way of linking that in and supporting.
Definitely. Just aware time has flown by, so we'll sort of keep racing on. And I think there's a question as well. I guess that, yeah, we've talked about this, we've touched on this in kind of assessment, but also I guess we're just much more mindful. I say this, I think we're mindful for all of the young people that come through, particularly with BDD. So we've done assessments and treatment in sort of settings that feel more comfortable. So, I've done an assessment kind of in a dark room, for example, just to take that pressure off, somebody with BDD. So I think there's already adaptations and sort of allowing kind of masks on, or, there's lots of different things that we're doing anyway. But I think with the sensory sort of side of things, just ensuring that things like the temperature, the furniture, the lighting is all comfortable. And I'll often try and get the same room if possible in our building. Sometimes it's quite hard, but just trying to make it a bit more predictable, and so they know, because actually our rooms can really sort of vary. And yeah, sort of eliminating distractions. I think when we were doing online working completely during the pandemic, it was very, very challenging. I think it's hard anyway for people with BDD to do some of the online work, we're finding, because of the whole camera sort of issue. But sometimes it's hard for them to get into the clinic, so we're trying to find ways, like hiding their own sort of reflection back and things. But actually, when we were doing completely online treatment, it was really hard because the phone would be going off, somebody would be knocking on the door, there'd be pets. So just being really, really strict about that and sort of contracting, sort of finding a quiet space and make sure there's no distractions. Basically replicating what we would be doing sort of in the clinic, but also ensuring there's no distractions in the clinic as well. So maybe finding a quieter corner, and so forth. And just be mindful of what feels comfortable. So if eye contact's really tricky, not sort of being right sort of in somebody's face, even sort of sitting to the side might feel a bit easier. I think Elif sort of mentioned this earlier about sort of if they need breaks and so forth, if there's any other things that they need in session to really just take the edge off because it's kind of, yeah, it can be very overwhelming, sort of sensory kind of overload. Even sort of being in the waiting area, we've had some young people that have just found that really difficult. So we say to them, there's a quieter room they can wait in, or they can wait outside, and then we can collect them from there. So just be really thoughtful about those things, because yeah, then in treatment you're doing exposure therapy. So if their baseline anxiety is already really high because of all of these things that could be kind of supported with, then it's really, it can make sort of exposure therapy harder. If we move on, just keep an eye on these questions as well. Yeah, and then just checking things are understood, just ensuring, my pace is going completely off now because I'm speeding up, but just checking that things are understood, that the pace is right for them. Some, people really vary, it's very individual. We always make sure at the end of session there's time for questions, or like today we said, to ask questions as you go along, sort of giving multiple choice things. So sometimes just a couple of options. Giving too many options can be really hard, but I find today in the session I was doing, it was almost like, is it this or this, to support the young person, because they were sort of struggling with the question I was asking around anxiety. And yeah, just keeping it really sort of visual, as we've said, writing things down, and using prompts as if needed for sort of, I find this across lots of young people we work with, any prompting to do kind of homework and so forth. And just, I think one thing, is just being really clear about sort of the plan at the beginning, and making sure that there's a plan at the end of treatment that is really, really clear, and we get everybody to write things down. Elif, did you add anything?
I think it's just, again, it's sort of different aspects weaving into each other, I guess, in terms of that predictability and making sure there's a clear plan from the beginning, and the multiple choice as well, and making that visual can be really helpful in sort of taking the pressure of having to think and generate some of those responses that can be really hard as well. And yeah, we can really see the benefits of that in engaging the young person.
Definitely. So if we go on to the next slide. Yeah, and then some things that are tricky, but they're not sort of impossible to work with, is, I guess, we're very mindful that because of the sort of sensory sensitivities, that actually some of that may come up in sort of when people are feeling anxious, or when they're doing exposure. So I know when I'm feeling anxious, I get a bit hot and bothered, but I can sort of tolerate, anxiety is horrible, and I know it habituates. But I guess if there's sensory sensitivities around sort of hands feeling clammy, or things are sort of around that actually, and we've given an example, like a BDD example, of kind of having hair down. It may not just be to do with appearance concerns, it might also be sort of sensory sensitivities. It's just being really mindful of that, and appreciating that perhaps sort of habituating may take a bit longer. And I think sometimes, I don't know what you do, Elif, but sometimes I might ask for different sort of measures, which can be a bit hard, but sort of think about sort of how anxiety is coming down, and sort of getting them to tap into another feeling, like their heart racing, or their stomach, or their breathing or something, and then sort of thinking, and what about sort of your clammy hands, how's that feeling, and sort of getting a sense of that, because you can still get that learning around sort of anxiety habituating, but perhaps that sort of, those other feelings are really uncomfortable, but that's part of anxiety, but also something to do with autism. So it's just some of those nuances, I think, because what we want in treatment is somebody to get the experience of facing their fears and feeling like they can sort of cope with that. And of course, then we know with the sensory sensitivities that can really enhance and kind of make the anxiety sort of feel worse. And it's just trying to sort of unpick that. I don't know if that's kind of your experience, Elif, as well.
Yeah, absolutely. And I guess the only thing I think I've noticed at times, it's also a helpful opportunity to separate out, again, sort of the aspects of the BDD compulsion that might also be driven by autism as well. For example, there might be something about having hair up that is driven by appearance worries, but there also might be something about having hair down and the sensory impact of that. And just thinking about that a little bit when you're working that into the exposure and response prevention task as part of treatment, could be quite helpful too.
Sorry, I lost my voice. And also, yeah, I guess something, and it can be linked to sensory sensitivities, but often some of the, what we ask people to do is predict how anxious they might feel. And sometimes those predictions can be off for many people, but actually sometimes we find that there may be some stronger sort of emotional reactions in those with autism just because of some of those vulnerability factors. So we might sort of break down tasks even into smaller steps, and making it really sort of gradual and sort of sitting with somebody, for much longer. So we might extend sessions if it's taken longer, if the anxiety's gone higher than expected. Usually what we do in sessions is we might do one task and then get them to practice it sort of for homework, and then they come back and they move up sort of their hierarchy. So hierarchy is where we get them to list all of the compulsions that they're doing, all of the behaviours to try and sort of hide or fix their appearance, and work through them from the easiest to hardest. But what we often find with those with autism is you might sort of stay on the same step for a while and do lots of repetition of that in sessions before they're ready to move on. Hence why we think sort of extending treatment, that's another reason we think that's quite helpful. But we do really break it down. So it may be, with that example of hair up, hair down, if it's to do with BDD, maybe sort of doing a little bit down, a little bit more. It might be just really breaking that down into really small steps, or sort of saying, okay, can you do it for 5 minutes this week, try it for 10 minutes. So really gradual, and lots of incentives that I think particularly for younger children and people with autism, I think it really helps to incentivize and do some reward charts. And yeah, sort of tolerating uncertainty is something that I think lots of us do struggle with. I certainly do. But then if you have autism, it's a kind of an added part of that. And I think that can make treatment a bit harder, and sort of the unpredictability. And I think also what you were saying earlier, Elif, about some of the social aspects of this as well, where sort of there's the unpredictability and changes, but also maybe find it hard to read other people. So if you're doing an exposure task and you don't know what's going to happen, but also people around you are really unpredictable and you're misreading situations, it can be really, really kind of hard. And so it's just been really sort of thoughtful about that, about trying to sort of control aspects of that. So maybe inviting somebody into the session to do a task if it's just being around other people as part of it, and trying to plan as much as possible. But we have, there is some work that's been done that if it's really getting in the way in terms of that kind of aspect of autism, where it's really hard to kind of have flexibility and so forth, there's a particular type of sort of program called cognitive remediation therapy, which is about trying to build up flexibility and so forth, that actually sometimes that that or those principles of trying to do other things outside of BDD a bit more flexibly and being able to tolerate that kind of feeling of things not being completely sort of in control or slightly unpredictable can be a helpful sort of launch pad to then when you're doing that kind of work in BDD. So I guess with this aspect, it's just identifying it. If it's becoming problematic and interfering in treatment, then it may need some addressing outside of the kind of BDD treatment to kind of support that work. And we're on to sort of the conclusions before we finish off with some questions. So we think that those with autism are vulnerable to developing BDD. We think the rates are possibly comparable to those that we see in OCD. So around sort of a quarter of those with autism may also have BDD, but we have no rates at the moment to kind of back those figures. And should say, those figures are coming from a specialist clinic. What we really want to do is kind of screen for BDD in the whole population and see how many of those have autism and vice versa in an ideal world. And I think some research is underway sort of looking at that for us to get some idea of that, but we suspect it's really common to have both. And actually, disentangling BDD from autism can be tricky, but also it's really important because it's thinking about what's going on for that person, but also what you're targeting in treatment, remembering that BDD is treatable, but autism is part of the way somebody is, and there's some really positive parts of that and real strengths in it. I think I've said this all the way along, more research is needed in this area, and we're doing lots of work on this because we think it's a particular population that needs that kind of thinking around it. And hopefully we've been able to summarise some of those adaptations we think we're just making in our treatments, but what we want to do our next stage is kind of evaluate that and think, well, which ones are the more important adaptations, what are needed. But I think the good news is that actually CBT for BDD is effective in those with autism just as much as it is for those without. And I think that is the good news story. And I suspect it's some of those adaptations, but I think irrespective, there's good treatments out there, which is it's really positive. So thank you for your time. Should we just go through some of these questions, Elif? So we've kind of addressed a couple. So about perfectionism and is perfectionism for BDD, OCD or autism? I would say all of the above. I don't know what you think, Elif. I think it's something we see across all those groups, don't we?
I think it comes, I completely agree, and I think it comes down to that sort of idea of transdiagnostic processes as well, that we do see perfectionism across sort of different conditions. And yeah, it commonly comes up in BDD as well.
Definitely. And then Judith, I know you sort of have some specific questions about our service. So you're out in quite far from us, and we've done an assessment on whether we would do treatment remotely or it's handed over to a local team. Generally speaking, I guess, you know, we wouldn't be able to go into sort of detail here because we didn't do the assessment and so forth. We don't know what's recommended, but as it stands, you know, when somebody's assessed by our service, we do the treatment and then we think about sort of how to deliver that. So sometimes, you know, we do a mix of in-person and online. I think our sense, I don't know what you think, Elif, is we think for young people with BDD, sort of in-person is better. Particularly at the beginning of treatment. I think I'd really like to be seeing somebody in person to get to know them, sort of build up that relationship. And then if they're sort of doing quite well and they get the principles of kind of what they have to do, and I feel fairly confident, particularly when there is a distance, and we might move to online. And we do some home-based sessions as well. Yeah, I don't know what you think, Elif, is that sort of your perspective?
Yeah, and I absolutely, and I think lots of young people can also prefer the in-person, find that a bit easier than being online. But there are aspects, I guess, of, like you say, once that contact has been established, there might be, yeah, very valuable ERP tasks that happen online as well. And I think we want to be flexible with that, and we can definitely alternate between some of the home-based options as well to support the young person to attend.
Definitely. We tried to take as much learning as we could from sort of the pandemic, where it was so extreme. It was all online, and I did some entire treatments online, and it was quite effective. But yeah, we're still looking at sort of the results. We've got some results that suggest perhaps for severe OCD they don't do as well as they would do in person, but we yet to find out for BDD. A question from Tanya. Are you considering the overlap with gender dysphoria with AFAB autistic young people? Sorry, I don't know. Do you know what AFAB is?
I'm not quite sure I know what the acronym means. I don't know if you are able to type it in, Tanya, sorry.
Perhaps we can come back to that, because then we can answer it more fully. Have we noticed that individuals with autism and BDD are more concerned with certain body parts? Yeah, we're interested in looking in that in our research, but I don't know. I don't know if you've noticed, Pat, you see many more people for treatment than I do, but I haven't seen particular patterns yet, but we do take measures, don't we, of kind of areas of concern. So that's something we want to look at, because we're just curious as to whether there is something in that. But I don't know, Elif, if you have any clinical... I do lots of assessments. I haven't really noticed a pattern.
I think I would say the same, that there isn't a specific pattern that stands out, but often things can feel a bit different when you've got a pool of data together, and that might sort of throw up things that you haven't quite sort of noticed from moving from one person to the next. Yeah,
I would agree. Oh, thanks, Tanya. You've said assigned female at birth. So whether we're considering with gender dysphoria with assigned female at birth autistic young people. I guess gender dysphoria slightly, you know, we are seeing lots of young people, or we're interested particularly in young people with BDD and gender dysphoria, because we think there's some interesting overlaps, and we've seen some people will have done treatment for one and you know, in the context of the other. I guess our service is more coming from the angle of BDD, and then sort of some of those, or like we think a quarter of those have autism, so we're less sort of from a gender dysphoria service or autism service. But I'm not sure of kind of research. I think from the young people I've seen with autism and gender dysphoria, when they've had it in the context, there's some interesting, it's a really interesting area. And actually our trust is now going to be hosting the gender identity disorder clinic, and I think that overlap between autism and gender dysphoria is really important to think about. But yeah, I don't feel like I can really answer that, because I guess our service is a BDD service predominantly, but I don't know if you wanted to add anything to that, Elif.
But I guess sometimes, if I'm remembering correctly, we can have question from past referrals that the question may have been around, is this BDD, is this gender, is there an overlap there? So I think from the assessments I can remember, there have been some thinking around trying to separate out and thinking about sort of the concerns that the young person is bringing and how much of that is driven by gender dysphoria or BDD, and whether there is those sort of conditions present. But yeah, I guess it's not an area that we, I guess there's a lot more still to be sort of learned.
Definitely. Rupert's asked, what are the metrics for determining whether treatment's needed for BDD? I guess from our perspective, if you have BDD, which means it's interfering and distressing, so kind of those preoccupations and the behaviours, you know, that would warrant treatment from our point of view. So there's not particular cut-offs that we use in our service. I think it's just if there is interfering and distressing sort of preoccupations and associated kind of behaviours that are trying to hide or fix those perceived flaws, that would warrant some support and treatment. I don't know whether you would agree, Elif. For our service, we don't have a particular sort of cut-off on measures necessarily.
No, I would agree. It's very much, once that is going to be a helpful package of treatment.
Yeah.
We go ahead with.
Great. And finally, from Rachel, so because that you sort of get the sense that the autism symptoms that you have aren't as prominent as your BDD primary diagnosis, don't take it seriously, I don't think it's relevant to get a diagnosis. What should I do? Do I have to accept that getting BDD help is more important than diagnosis of autism? It's really hard to say. I think sometimes I struggle with this part because, you know, we would want definitely more information and probably see you clinically. I don't know, Elif, if you wanted to kind of say anything about that.
It just got me thinking about, I guess, aspects that someone might find helpful, for example, adjustments and adaptations that we've been thinking about today that might be shared, for example, with their clinician or their team, for example, to consider and think about, regardless of whether a diagnosis is in place, for instance, might be a way of communicating that. But similar to you, Amita, it can be hard without having more information, just sort of thinking about that more fully to give a more helpful response.
Yeah, and then there's the added thing about sort of getting a diagnosis of autism, you know, and other things it can open up, so not just about BDD treatment. But it's hard for us to sort of comment on particular sort of scenarios necessarily in this kind of forum. But thank you for kind of sharing that and kind of asking those questions. I'm really sorry we did go over time. We actually had lots of material, but some really great questions, and I hope and we hope you found it helpful. And I believe this will be available to watch on the website at some point. So thank you for joining us, and please do tune in for more of the autumn webinars.